A blowout fracture is when a blunt impact to the eye results in an isolated internal fracture, the force often pushing the still intact globe back into the orbit. The most common causes are from a car crash, the human fist or elbow, and sporting injuries. Following trauma, the ocular structures absorb shock to prevent damage being done to the eyeball itself. This is explained by the hydraulic and the buckling theory, where the pressure from the orbital contents compressing transmits to the orbital walls, resulting in the weaker sections fracturing the orbital floor and the medial wall, and simultaneously displaces the globe. Following this fracture, the orbital contents depress and soft tissue, often an extraocular muscle, gets stuck. Edema and bruising can show externally, whereby proptosis, diplopia, and ocular motility deficiencies are common. Enophthalmos and cheek or upper gum desensitization is possible in severe displacements and consequential intraorbital nerve injury.
Most functional issues are due to inferior rectus muscle or periorbital soft tissue entrapment, which may restrict extraocular muscle movement, causing diplopia. As an optometrist, this means the affected eye may not move. The ocular motilities affected in blowout fractures are supraduction, abduction, or both. For short-term effects, the affected eye has poor vision, clinically noticed on entrance VA testing, and a motility defect, so always check their ocular motilities. Traumatic optic neuropathy is a red flag, thus you must do visual fields to rule this out. For long-term effects, there's broadly 3 outcomes. 1, if caused by edema and hemorrhage, there's spontaneous recovery within 2 weeks. If caused by vascular and neurological damage, it may take many weeks to resolve. And 3, permanent long-term damage even after surgery if caused by scarring, entrapment tissue dysfunction, and or severe neurological involvement.
When the patient enters the consulting room, entrance tests including motility testing, pupil testing, and exophthalmometry should be performed to evaluate the extent of impairment, possible optic nerve involvement, and monitor its progression. Visual fields of blowout fracture patients should also be evaluated using Hess charts. However, a diagnosis can only be made radiologically using a CT scan with contiguous thin axial and coronal sections. Look for the classic teardrop sign for inferior rectus strangulation. In cases where motility defects are not severe, diplopia often resolves without intervention, so wait at least 14 days before considering ocular surgery. Some patients even adapt and are content with a decreased visual field despite the misalignment. Other interventions such as steroids can be used to help with edema in acute stages, and regular medical follow-up should be made to observe the possible regression of diplopia.
When someone comes in with a vertical misalignment of the eyes in primary gaze or symptoms of vertical diplopia, how do we differentially diagnose it? Consider a cranial nerve 4 palsy where the superior oblique is affected and makes a fellow eye look depressed. Do a 3-step test to confirm which muscle is palsied. Also observe a head tilt away from the palsied eye. In a third nerve palsy, there will be hypertropia due to a supraduction deficit. However, observe other signs including exotropia and notable ptosis. Skew deviations are caused by damage to the prenuclear vestibular input to the oculomotor nuclei. Other symptoms include binocular torsion and a head tilt towards the side the patient perceives as vertical. In congenital strabismus, a unilateral cover test will show movement where a blowout fracture ocular motility defect will not. Asking a thorough history and having previous records will aid in diagnosis.